Okay, so this lecture is on shock. First thing I want to say that is, regardless of the type of shock, it all eventually leads to hypotension and anaerobic cellular metabolism. It's basically metabolism without any oxygen. Okay, so hypotension and anaerobic cellular metabolism all leads to that, no matter what type of shock it is. And shock is basically something happens to the body and causing a decrease in perfusion and decrease in oxygenation, leading to hypoxia, ischemia, and multi-organ failure, and possibly death. Okay, so it's going to be a perfusion oxygenation problem. So the first thing we'll talk about is hypovolemic shock. So hypovolemic shock, there's two types here. There's due to bleeding or due to dehydration. And the one due to bleeding, basically, something's causing the patient to bleed, whether externally, internally, whether it's a car accident, huge trauma, or post-surgery, and they're bleeding internally, or it could be a patient with inadequate clotting, patients such as those with liver disease, bone marrow suppression, which we just learned about, cancer patients, patients on anticoagulant therapy, and patients with hemophilia. These patients can bleed out. So this is going to be in the bleeding section of hypovolemic shock. And with these patients, they're losing blood, so you're going to see the hematocrit and the hemoglobin numbers go down. And then there's also the dehydration cause. So dehydration, these are your patients' severe nausea and vomiting. They have massive diarrhea, heavy diaphoresis. They might be on Lasix, some sort of diuretic therapy. They might be on NG suction. We know patients with diabetes insipidus have high risk for hypovolemic shock, right? Huge amounts of loss of fluid in a short period of time. And then your hyperglycemic patients, the patients with the poly, right? Losing tons of fluid. So all these patients are at risk for this dehydration. Now with the dehydration, you have a relative increase in hematocrit and relative increase in hemoglobin, and you know that's due to hemoconcentration, right? So that will be how you determine these two. Remember that when you look at that. And once again, we know that they don't have enough blood for whatever reason. This causes a decreased perfusion, decreased oxygenation to the entire body. Cardiogenic shock is due to some sort of heart health problem, usually because of a heart attack, but it could be from dysrhythmia such as VFib or VTAC. Maybe cardiomyopathies due to some sort of virus or toxin, any type of myocardial degeneration. Basically anything that is decreasing perfusion to the body due to ineffective pumping of the heart. Okay, that's going to be your cardiogenic shock. And the last one here is distributive shock. There's another one, obstructive shock. I didn't put that up there, but basically that's similar to cardiogenic shock, except that it's not caused by a pump failure. That's more like, you know, patients who have like a cardiac tamponade or some sort of tension pneumothorax, something that's blocking the ability of the heart to pump, not necessarily the heart sick, but maybe, you know, the fluid around within that pericardial space causing decreased perfusion to the body. So that's obstructive shock, but I'm not going to go over that. You can read that on your own. That's on page 810. But distributive shock, there are several types here. The main problem with this one is that there's vasodilation or leaky vessels that causes the fluid to come into the interstitial tissue, so it's not in the vascular space, so that causes a decrease in perfusion or decreased O2, or massive vasodilation causing a relative decrease in blood pressure and also decrease in perfusion and oxygenation to the body. So we know that anaphylaxis causes the bronchoconstriction, we hear about all the time, but anaphylaxis is also a chemical induced shock, right? Something happens, your body comes into contact with something, and now your body is responding, and it causes a decreased tone in the blood vessels, causing hypotension. Sepsis causes an inflammatory response, which not only causes massive vasodilation, but it also causes the blood vessels to be very leaky, so the blood leaks out of the vessels and goes into the tissue. And neural type problems like a spinal injury or head injury or even anesthesia or severe pain or severe stress can cause like a decrease in the sympathetic stimulation, so causing just less muscle tone in your vessels, and that causes a type of vasal dilation as well. Okay, so one of the earliest things that you're going to see is you're going to see the heart rate increase. Okay, so that's one of the early signs. You're going to see this increase in heart rate and possible decrease in urine output pretty early on. So those two are things you want to really keep out for. And so I'm going to start with the neuro changes. The neuro changes, the patient's going to become very thirsty, and this thirst is basically a response in the brain saying, hey, we have less volume in the body, and it's telling the patient to increase the volume by drinking something. So you're going to see that right away, thirst. I've said it several times in the book. I hope it comes up on the test. And then you're going to see anxiety, restlessness, and agitation, right? Anxiety, restlessness, agitation, that's all due to decreased oxygenation. And we know that. We know that when we see this on a test, the patient is high risk for hypoxia. Okay, so these are things that you're going to see. And in the later stages, you possibly see lethargy, confusion, right? This is the later stage. Absent DTRs or decreasing DTRs, weakness, decreased pupil reactions, and then in the very late stages, that can even lead to coma and death. Okay, and in the heart, you're going to see, we spoke about the decrease in mean arterial pressure, and I said that mean arterial pressure is basically an average of the blood pressures in the body, and you're going to see a decrease in that. Why? Because there's less volume being perfused to the body, whether it's because of I'm bleeding, I'm not taking in enough fluid, my heart's not being out enough, my heart's not pumping enough blood to the body, or I have a massive vasodilation where my or my blood is being moved into the tissue rather than remaining in the blood. Oh, sorry. With this one here, I'm going to jump around a little bit here, but this third spacing vessel leaking situation. So there are a couple of conditions that can cause this. In the book, it calls it the capillary leak syndrome. So something happens to the body, and then there's like biologic mediators that change and the integrity of the blood vessels. So the blood vessels become more leaky because the capillary pores become bigger, and also this causes a loss in plasma osmolarity. So you know, like normal plasma osmolarity is like 270 to 300. So when the osmolarity in the plasma decreases, right, then you're going to get a shift out of the vessels. And then also there's going to be, and this also, these biologic mediators in this situation causes an increase in hydrostatic pressure. And you know, hydrostatic pressure is basically pressure pushed against your blood vessels, right? And so these biologic mediators caused by possibly, you know, severe burns, liver disorders, ascites, infections like peritonitis, paralytic ileus, severe malnutrition, large wounds, hyperglycemia, kidney disease, hypoproteinemia, so decreased protein in the serum, trauma. These different conditions can bring about this capillary leak syndrome. So this is what this is, this vasodilation and leaky vessels that causes third spacing, okay? And that's on page 812. So back to this. So we talked about the mean arterial pressure. You want to keep that above 60. And in the early stages, you're going to see a decrease in, a slight decrease in this mean arterial pressure, right? The average pressures, blood pressure in the body. And when you see a decrease in blood pressure, you will see this increase in heart rate, this natural compensatory increase in heart rate. That's an early sign, okay? And you're going to see a decrease in stroke volume. And the reason why is because you have less volume, right? Whether it's less volume or your heart just can't get it out of there, you're going to see this decrease in stroke volume. And because of the less volume, the pulse will be very thready, or possibly even you might not be able to feel the pulse. Okay, you're going to get this narrowed pulse pressure. This narrowed pulse pressure occurs because vasoconstriction causes an increase in diastolic, and in the early stages does not cause any change in systolic. So, normally normal pulse pressures are like 40, right? Something like that. I believe, like, if you had a normal blood pressure of 120/80, then the difference between the two would be like 40. That would be like normal. So as that number gets smaller, this condition is actually getting worse, because in the early phases, the diastolic, like I said, goes up. The systolic remains the same, but you'll still get that narrow pulse pressure. And then in the late stages, we'll explain that as well, but there will be also changes in the systolic. And an increase in narrow pulse pressures. The main thing is you don't want this narrow pulse pressure, because that means things are getting worse, okay? And you're going to get a decrease in blood pressure, right? Less volume, less pressure, and decreased cardiac output because you have less blood to pump to the body, right? And then you're going to have that slow cap refill because your body's not getting the amount of blood that it needs. And the lungs, you're going to get that increased respiratory rate. Why? Because you have decreased oxygenation. The lungs are going to make up for it, okay? And so you're going to get increase in respirations, but you'll have these shallow breaths, okay? And on your ABGs, you're going to see an increase in CO2 and an increase in potassium. So why do you see an increase in CO2 and an increase in potassium? So as your body becomes more and more hypoxic, it goes into this anaerobic metabolism. And like I said earlier, regardless of type of shock that you have, your body will eventually become hypotensive and it'll go into anaerobic metabolism without oxygen. Now, when you go into anaerobic metabolism, a byproduct of that is lactic acid. So as you are, and as lactic acidosis builds up, you become more acidotic, right? And we know that when your body becomes more acidotic, your potassium always goes up as the exchange. This is potassium-hydrogen exchange in your cells, right? But not only that, as this anaerobic metabolism occurs, it also increases these toxic metabolites in your body, and it causes these toxic changes in your electrolytes and in your ABGs, and that also contributes to this elevated potassium, okay? So you're going to see this increase in CO2, this increase in potassium, and obviously a decrease in O2, right? This is kind of one of the biggest problems anyhow. This is the biggest problem. And you'll see the cyanosis, especially around the mouth, and we already talked about this. Okay, so the kidneys. We talked about decreased urine output, okay? Because your kidneys are, the kidneys know you're in trouble. So you're going to have that decreased output. And in the early stages, the patient will still have decreased urine output even if they're drinking a normal amount of fluid. And that decreased urine output, when the kidneys are concentrating the fluid, you know that you're going to get an increase in specific gravity of the urine, okay? And then you might even see the sugar and acetone in the urine. That has something to do with this whole anaerobic metabolism as well. And then the skin, you're going to have this cool and clammy skin, and the skin will be moist, and moist not because you're sweating, but moist because the moisture is not going to be evaporated as quickly on cold skin, and then your mouth will be dry. And this makes sense because, right, you can have a dry mouth. Why? Because you have less fluid in the body, or less fluid getting perfused to the body. And you have that cool, clammy skin because as your body gets less blood and less oxygen, naturally, to compensate, it's going to shunt the blood to the vital organs, right? Your kidneys, your lungs, your liver, your brain, your heart. And the guys get left behind are like the skin and the GI tract. And these guys, this one, as you see in your gastrointestinal tract, you'll have decreased motility. What does that mean? It means you're going to have constipation, decreased bowel sounds. Okay, everything goes down. So those are the signs and symptoms that you're going to see with both hypovolemic shock, cardiogenic shock, and for the most part also septic shock, which we're going to go into in the next lecture. But there are some differences with septic shock that I will go over. So let's go over the stages of shock. I know that we need to know this. So in the first initial stage, you're going to see a slight decrease in the mean arterial pressure from 5 to 10 millimeters of mercury. So let's say your normal arterial pressure is 65, now it will be 60 or 55. Okay, so just 5 to 10. So at this point, your body's still pretty much able to compensate. Okay, your heart's going to beat faster. You know, like immediately we see that early on is that increase in heart rate, and your body's able to compensate for this, and you're still getting your organs and your body's still getting perfused. So you'll see, and then you know the sympathetic nervous system is stimulated, and you'll have a mild vasoconstriction as well. So early on, you'll see this increased heart rate and this mild vasoconstriction, and this slight decrease in your mean arterial pressure. But as this progresses, you're going to see more of a dip here from 5 to 10 to 10 to 15. So an increase in a larger decrease in your mean arterial pressure, right? So less blood's being perfused to the body now. Now you have moderate vasoconstriction, not mild anymore. And now you really have that increase in heart rate, and a decrease in your pulse pressure. Okay, and at this point, the heart's really not able to compensate fully for what's going on. So the endocrine system and the kidneys are going to go ahead and jump in and give the body a hand here. And these are all compensatory mechanisms, okay? So basically, you know, there is going to be a release of aldosterone, a release of ADH, a release of norepinephrine. And the point of all this is, you know, aldosterone is going to go ahead and hold on to that water and hold on to that sodium. You know, ADH causes the body to reabsorb water as well, and all these guys cause vasoconstriction to occur, and also epinephrine and norepinephrine also cause vasoconstriction to occur. Okay, and then the kidneys are going to decrease that urine output and holding on to that fluid, and the body's the patient will be very thirsty because of that decrease in volume. And now there's definitely anaerobic metabolism going on in the non-vital organs. Before, the body was able to compensate. Now the body is not able to compensate as well, and in your non-vital organs, such as your skin, there's going to be anaerobic metabolism going on. And so there's going to be a mild acidosis, because like we said, right, anaerobic metabolism as a byproduct gives off lactic acidosis and can cause metabolic acidosis. So you're going to see a mild acidosis and mild elevation in potassium in this stage. And in this stage here, if the body can compensate and and appropriate interventions are being given, the patient can be in this stage for a few hours and really can possibly come out of it with no permanent damage. Okay, so this is really, if you haven't caught it here, you really want to catch it here. Now the next stage is the progressive stage. Okay, so we see a mean arterial pressure decrease of more than 20 millimeters of mercury. Okay, the patient's pretty much in trouble now. There's no oxygenation to the non-vital organs. Okay, and there's moderate acidosis now. There's an absolute increase in potassium, and now there really is ischemia going on. And so ischemia causing cell death and cell destruction. So we have no oxygen to the non-vital organs, hypoxia in the vital organs, and then we have ischemia to the cells, and so causing cell destruction and cell dysfunction. The patient now is going to be very, very severely thirsty. They're going to have extreme anxiety. Okay, their blood pressure is going to has dropped significantly from their baseline, whichever that is, and their nail beds and mucous membranes are going to be very blue. Their skin will be very cold, and before they did have a decreased urine output here, they might actually have no urine output. And one of the main things that you know that you're in trouble is when your pulse ox has decreased by 5 to 20%. I mean, if you were at 95, or the patient was at 95, the patient's now at 90, okay? Or the patient was at, 100%, now they're at 80. I mean, you know that they're in a lot of trouble. So, sorry, I didn't mention here, but the pulse ox here, you're going to see a decrease in about like 2% to 5%, okay? So, if it was at 100, now you're at 98 or 95. So, like I said, the patient's in trouble here, but they can be here for a little bit, a couple of hours. When you go into the progressive stage, if you don't fix this problem within the hour, the patient's going to absolutely have permanent organ damage, okay? Now, if we move to the refractory stage, there's not much written here because the patient has severe hypoxia, necrosis, okay? Doesn't matter what therapy is done at this point, the shock can never be corrected. Even if you got the main arterial pressure up to normal again, the patient's the problems are going to be permanent. Okay, there might not be a pulse. The patient will be very cold. Their skin might be very dusky looking, grayish. Their respiration will be very shallow, and you might not even be able to measure their saturation. Okay, and this leads up to our lecture regarding multi-organ destruction. So this is the stage. The refractory stage is not where the patient wants to be. They're in a lot of trouble. Okay, so we'll talk about risk factors and a couple of treatments. And like I said, this lecture is mainly for hypovolemic shock and cardiogenic shock. Septic shock I'll go into the next lecture because those, septic shock is obviously a problem with an infection, so we'll need to also address the infection. Okay, so risk factors. Any patient that has experienced trauma, surgery, acute hospital stay, patients stay in the hospital, get urinary tract infections, become septic, not unheard of. Patients with decreased mobility, decreased cognition, always in trouble. Patients and NPO patients or patients with nausea and vomiting, or vomiting and diarrhea, those patients are at very high risk for dehydration, right, and hypovolemic shock. Most of these different types of shock, the elderly are most susceptible. The only one that's a little bit different is hypovolemic shock due to some sort of crazy trauma. That's really more common in the young. Okay, so that's really the only difference that I had noted there. So treatments, we know that it's an oxygenation perfusion problem. The patient's going to get oxygen, however you can give it to the patient depending on, if you can put on a nasal cannula and they can become well oxygenated from that, that's great. If not, a mask, a non-rebreather. If they need to get intubated because they're not responsive, then that's what needs to be done. Normal saline, the fluid of choice to go ahead and restore that volume. Normal saline is a crystalloid solution. How you can remember that is crystalloid. I always think salt crystals, crystalloid solution. This is really the solution of choice, and as we know, it's the only one that can be used with to transfuse blood or with blood. Lactate ringers can also be used. Lactate ringer basically can restore volume, and also correct some of that acidosis. But lactate ringers cannot be used with whole blood. So depending on how the patient's doing, if they're going to get a blood transfusion, for example, if they have moderate hypovolemia, they might just get packed RBCs. If they even need this is kind of progression of how bad the situation is here. If they have extreme hypovolemia, a lot of blood loss, or extreme hypovolemia, then we can even give them whole blood, right? Because this one here doesn't increase the patient's risk as much of fluid volume overload, but this does. But if they're severely hypovolemic, they can get whole blood. They can get plasma. This is when hematocrit and hemoglobin are pretty much normal. Maybe the doctor doesn't know exactly what's causing the shock. Plasma can be given to kind of just restore that the volume, restore that osmotic pressure. Dopamine. So when all these things are given, all these interventions, and the patients still can't come back from it, and is not stable, then drugs can be given as well. So drugs such as dopamine or norepi, which is Levophed, can be given, and that basically causes a vasoconstriction, right? So the vasoconstriction, can increase that perfusion to the heart, but problems with giving dopamine and Levophed is also increases myocardial oxygen consumption. So now you have to worry about patient possibly having chest pain because now the heart demands more oxygen. So that's something to look out for, right? You don't want the heart to become ischemic. And another thing to look out for is, this causes vasoconstriction, which is good because we want to bring, increase venous return to the heart, but it can cause too much vasoconstriction. So you want to look out for hypertension. And hypertension is an absolute sign that the patient has been overdosed. Okay, so you're going to monitor blood pressures every 15 minutes. Okay, blood pressures every 15 minutes. Now, dobutamine can be given. This increases the contraction of the heart, and when increasing the contraction of the heart is obviously going to give the body more blood. So dobutamine is good. Basically, it's similar to digoxin, but digoxin does take some time to build up in the body to become therapeutic, and I believe there's like a loading dose of digoxin. It's just not as fast. So dobutamine is really the drug of choice here. Same thing, it increases that myocardial demand of oxygen. So now you still have to look for that chest pain. I mean, the patient can possibly have a heart attack because of the increased demand of the heart for oxygen, and then it can also cause hypertension. So hypertension will be, obviously that hypertension is a sign that the patient has been overdosed. So blood pressure is every 15 minutes to monitor that when being given these drugs, okay? And you want to elevate the legs because we know that we have a perfusion problem, right? So you want to elevate the legs and the head of the bed flat or no higher than 30 degrees, okay? Elevate legs, head of the bed, no higher than 30 degrees. And NitroPress or Nipride are basically, these are like nitro drugs, and they cause more vasodilation in the coronary arteries, so it increases perfusion to the heart. This is something that we want, but though it is more sensitive to the vessels in the heart, it can also cause a systemic vasodilation, and that can be a problem if the patient's already severely hypotensive. So if these are given, once again, monitor blood pressure very, very carefully because you don't want to cause the patient to become more hypotensive. Okay, and if vasoconstriction occurs too much due to these drugs, you can have a decrease in urine output. So very careful. You got to monitor the urine output, monitor for chest pain, and then monitor the IV site because some of these drugs can be very irritating to the vein. Okay. And then the patient will possibly have a catheter that measures the central venous pressure. And this basically measures pressure of the blood going into the right side of the heart, and this measures obviously the veins, right? And then there can be an A line that's put in, and this is usually put into the radial or brachial artery, and this measures blood pressure in the arteries. So these two catheters here can be used to measure more accurately the blood pressure in the body, and then both can also be used to draw blood. So this A line can be used to draw arterial blood, and this central venous pressure can be used to draw venous blood. Okay, so that's it for the lecture on hypovolemic and cardiogenic shock. The next lecture is going to be on septic shock, and then I'll have a lecture on the multi-organ, the dysfunction syndrome as well. I hope this helped.